Good morning, and thank you for attending our Grand Rounds lecture. I'm pleased to introduce to you our speaker, Dr. Karen Joynt Maddox. Dr. Maddox is a cardiologist at Barnes-Jewish Hospital and an associate professor at Washington University School of Medicine and co-director of the Center of Advancing Health Services, Policy and Economics Research at Washington University Institute for Public Health. Dr. Maddox is a health services and health policy researcher with expertise in quality and outcomes measurement, value-based and alternative payment models, and health equity. She is an associate editor at JAMA and serves on a number of national committees related to quality and policy. We are grateful for Dr. Maddox's expertise on this topic and look forward to learning from her. At the end of the lecture, we'll leave time for questions. Please submit questions via the chat function on Zoom as they arise during the talk. We're pleased to offer both CME and MOC credit for our Grand Rounds conference series. To claim credit for today's session, text the code shown at the beginning and the end of the presentation to 804-625-4041. For questions or to log into your Cloud CME account, visit vcu.cloud-cme.com or contact Shannon Winston. I will now turn it over to Dr. Maddox.
Good morning, everyone. Thank you so much for having me. It's lovely to be with you, even virtually. I'm sure your spring flowers there are blooming like ours are here. Actually, I feel like we're between spring flowers and like summer heat takedown, but hope it is lovely there as well. Sorry, I'm not with you in person, but look forward to spending a little bit of time together this morning, talking about why value-based payment in cardiovascular care hasn't improved health outcomes. If I can advance my slides, we'll be in good shape. Okay. These are my disclosures, largely research related to what I'm going to talk about today. So intellectual disclosures, I suppose, if anything, in terms of the funding overlapping with what I'm going to talk about. Okay. So I'm going to start by talking about quality measurement. And, I think many of us practicing today sort of take for granted that we have data about what we do. And it turns out that wasn't always the case. So in the 1950s, quality measurement started with the introduction of minimum standards. So basically, what are the basic things that you should be doing when patients present with certain conditions? There was something called the Indicator Management System in the 80s and the OREX initiative in the 90s, and these were largely sort of part of JCO and JCO's precursor, really trying to get largely hospitals at this point to think about what kind of care they were providing in the hospital, but there was no national data. And you certainly couldn't benchmark yourself against anyone. You couldn't understand how you were doing on any sort of large scale, and very few hospitals were measuring processes of care in any meaningful way. So starting in the 2000s, something came together called the Hospital Quality Alliance, which was payers, Medicare, some big health systems, and said, all right, we really need to be doing this, right? I mean, this is not that long ago. We like data, especially when we're cardiologists, and we need to understand, what it is that we're doing for patients. And so the universal quality measurement era sort of started in the late 2000s when most hospitals signed on to attempt to measure their quality. Now, during this time, the measures were fairly minimal. So you can see here, for example, for heart failure, assessment of LV function, ACE inhibitor for LV systolic dysfunction, smoking cessation counseling, and discharge instructions. But during the first few years of the Hospital Quality Alliance, they did improve, at least smoking cessation counseling and discharge instructions, and to the degree that's documentation. But I think we actually did get more consistent at doing these things during this time. So now that hospitals were comfortable with sort of collecting data, we moved into sort of the reporting period. So the Medicare Modernization Act authorized these data to be collected nationally. And the first data became publicly available in 2004. 96% of hospitals were reporting by 2005 because their annual Medicare update was tied to payment. So all of them signed up. And we entered the era of process reporting, where you could go online and you could actually see how hospitals were doing. Now, what did this look like? These are basically the same list that was there during the initial phase. So things like aspirin for a heart attack, beta blockers, lytics, which obviously were a much bigger part of our practice 25 years ago than now. And you can see that all these things were, relatively uncontroversial. Obviously,
Not bad.
the beta blocker bit has changed, but, largely the same things as we think about now. So public reporting probably improved processes of care. So moving from 2003, where we really just started the data collection process, to 2008, where these things were reported publicly, you can see on the left for CHF and on the right for pneumonia, that the proportion of hospitals performing in that top bucket, that 91 to 100%, where we'd hope that people are, I think 100% is unrealistic for, missing a contraindication someplace, but that 91 to 100% bucket, we went up to about 50% of hospitals for heart failure and about 70% of hospitals for pneumonia, meeting those requirements. But here's where sort of the first interest, at least, for my interest in how this played out, comes. So public reporting of processes didn't improve outcomes. So here you can see from 2000 to 08, mortality for acute MI. We were doing pretty well in the red segment there, right, before hospitals were publicly reporting. And if anything, mortality improvements slowed after the introduction of hospital compare. For heart failure, you can see what looked like a pretty impressive drop, which then rebounded back up to essentially be no change as a result of public reporting of outcomes. And for pneumonia, pretty clear indication that downward progress in mortality rates actually stopped after the introduction of public reporting. Now, that doesn't mean that this is causal, but I think it does mean that we can fairly confidently say that public reporting of processes did not lead to improvement in outcomes. So because this is the government that I'm talking about, and because this all still seems like a good idea, we sort of doubled down. So we went from process reporting to outcomes reporting. So if it doesn't work to report processes of care in terms of improving outcomes, maybe we just need to report the outcomes. So that didn't work either. So starting in 08, you could go online and see mortality and readmissions. It was staggered, but for all intents and purposes, mortality and readmissions. And you can see in the orange line and the red line, it doesn't matter which one I tell you is which because they're the same. There was no change in the improvement in mortality over this time. If anything, it slowed during outcomes reporting. And our comparator group here was things like GI bleed, sepsis, UTI, all the other stuff in the hospital that was not CHF, acute MI, and pneumonia, and really demonstrating that, yes, we're gradually getting better over time, but there didn't seem to be any real drive, I guess, from process or outcomes reporting. So enter value-based payment. I'm not going to go into all of the alphabet soup today, but just know that all of us are living under these programs every day. So this is the way that Medicare now pays for healthcare, starting in 2011 with the Affordable Care Act. And things like the Hospital Readmission Reduction Program, the Hospital Value-Based Purchasing Program, and the Hospital Acquired Conditions Reduction Program will be very, very familiar to people who are in hospital administration, and basically take many of those same quality measures and now tie payment to them. So instead of just putting them online, now we're actually adjusting hospitals' payment based on their performance on a set of these measures. Now, that hasn't improved outcomes either. And, maybe that will come as no surprise since I've set it up the way that I have, but I think this was all actually quite well intentioned, right? Like people really did feel like measuring should improve outcomes, reporting should improve outcomes, reporting outcomes should improve outcomes. If we just put money on the table for improving outcomes, it should improve outcomes, sort of with the idea that like we can do better, and us doing better in the hospital in the ways that we can control should improve patient outcomes. I don't think that's unreasonable to think. But you can see here, this is broken into two graphs just because of the way that that HCUP releases their data. But you can see here that from 2010 to 2016, remembering that the HRP was introduced around here, the first year or so, there was about a 1% decrease in readmission rates, and thereafter there was nothing. So we've had no change in readmission rates since 2013, despite this program being ubiquitous, right? It's penalizing 80% of hospitals nationally. And if we look at mortality, that didn't improve either. On the left is using a non-HVBP control, and same on the right, just broken down by conditions a little bit differently. And you can see with the potential exception of a little bit of a dip in pneumonia mortality at the end, which actually turned out to be gaming of the codes, not actual mortality improvements, as was later discovered, there's really no evidence that this improved outcomes either. And nothing in value-based payment addressed access or equity. And any of you who are in clinical settings or who even think about clinical settings know that access and equity are an enormous part of how we think about outcomes in the hospital. We have persistent and profound health inequities in this country, right? You can see on the left graph of age-adjusted mortality rates per 100,000 population for cardiovascular disease among Black versus white. I think this one is men, but the women graph looks similar. And on the right, you can see overall mortality among people living in poverty versus people not living in poverty. We've known about these inequities, right? These are not surprises over the last decade even. We've really failed to make progress. And in the case of racial inequities, our progress has stalled quite a bit. In the case of poverty inequities, we weren't ever really making progress in improving these. We also know that adding risk factors together really compounds cardiovascular risk. And you can look at this map here and find where you all are located. But if you think about the intersection really of rurality, of poverty, and of minoritized race and ethnicity, you can see the places where there is certainly the most powerful decrement in cardiovascular survival. So the scale on the bottom is really quite notable. It goes from 76 to 546. So that top group is, above probably 440 deaths per 100,000 population. And the ones down in the bottom are, down in double digits. So these are huge differences in cardiovascular mortality. And you see that it really is the places where these risk factors combine. So you won't be surprised to hear, since I've told you value-based payment didn't improve outcomes, and that it also didn't improve equity. So you can see here readmission rates for Black versus non-Black patients. And we know that readmission rates are higher for Black patients. You can see that in the orange dots. No evidence.
Recording in progress.
No evidence over this time that the gap between these two groups has gone down. And that's the case whether you look at low-performing hospitals where there was higher readmission rates to begin with, or high-performing hospitals where there was lower readmission rates to begin with. Really no difference, and very little correlation actually between overall readmission rates and readmission rates for Black patients, as you can see in the graph. Now, alternative payment models, which I won't go into in great detail today, but you can think about these as being sort of value-based payment on steroids. It's now paying you, like this is bundled payments. It's paying you for a 90-day episode of care, trying to get a hospital to take accountability for that whole episode. And we did some work looking at the bundled payments program, similarly demonstrating that there was no difference in equity as a result of participation in this program. You can see there's big gaps, right? This is 90-day readmissions for Black versus white patients across 32 different conditions, I think, maybe 29. Big differences in 90-day readmission rates on the order of 5% or more. No evidence that vertical green line there on the graphs is associated with a decrease in gaps thereafter. And all of these programs, these value-based payment programs, are, as a consequence of their design, are really grossly inequitable. And we'll talk about a little bit about why in a minute, but basically all of them penalize hospitals that take care of poor and sick patients. Risk adjustment is inadequate, and therefore, and these hospitals struggle with fewer resources. And so therefore, most of these programs have really just taken money away from safety net hospitals and to some degree from large teaching hospitals in a way that, at least in my mind, cannot possibly be leading towards improved care. We also know that these inequitable penalty patterns, meaning the degree to which those penalty programs take money away from the safety net, hold by race independent of poverty. So if you look at practices that serve Black or Hispanic patients on the right, a high minority caseload, and on the left, hospitals that serve a high proportion of Black patients, in both cases, you can see that even controlling for poverty, these programs are disproportionately penalizing hospitals that care for marginalized populations, because that's who does poorly, and that's what the programs are pegged to. So in summary, this isn't the end. We still have like 45 minutes with me. Quality measurement as implemented through value-based payment, et cetera, have improved processes, have not improved outcomes, and have not improved equity. So this has bothered me, right? I started my career, my medical school 25 years ago, roughly. And when I got into this work in research fairly early on, I thought, well, this is going to fix everything, right? We just need to measure what we do, and we need to pay more attention and we'll work harder and it'll be standardized and everything will be great. And we didn't think about equity at that time the way that we do now, but we knew about, the basics of quality measurement. And so I will say that when I sort of pegged my career to studying these things, I thought they would work, right? I was quite enthusiastic, actually. I thought there were some major problems with the programs and their equity approach, but I thought they would work. They have not. So why, right? Like, why is what seems ostensibly like a good idea not working? And actually, to be fair, in non-government settings, if you think about door-to-balloon time, that's been an immense success, right? We never would have gotten there without measuring quality. So it's not that measuring quality doesn't work. It's that these federal programs to then sort of codify that into these major sort of federal efforts has not worked. I don't want to in any way take away from quality measurement. And I want to point out actually that door-to-balloon time, Get With The Guidelines, a lot of their other registries, there's been a tremendous amount of quality improvement that has gone on from a professional standpoint, right? But the sort of government version of improving quality really has not moved the needle. And actually, even those professional efforts have improved in very specific slices of care, but have not improved overall mortality either. Okay, so 3 reasons I'm going to spend the rest of the time talking about this stuff because I think it's interesting. I think we don't hear enough about it in cardiology, and I think it's where we need to be increasingly focused if we want to improve health outcomes. So first, value-based payment has been part of the drive toward consolidation and corporatization, and I think those have eroded human connections in medicine. I'll show you some data sort of to that end. And so that I think is a unintended side effect of all of this work to collect quality measures. The second, failures in the other part of the equation in terms of healthcare access have made gains in outcomes elusive because if people don't access care, if they have early barriers to access of care, by the time they get to us having their heart attack, whether or not we give them discharge instructions really has very little to do with their long-term outcomes. And then finally, even more broadly, health is really only marginally determined by healthcare. So we're going to talk about those 3 things for the remainder of our time. Okay, so the first, consolidation and corporatization. So the unintended consequences of much of this quality reporting effort is that the administrative costs are completely untenable. So on the left, you can see data from Larry Casalino, who surveyed a large number of outpatient practices and found that the total effort it took for physician groups to participate in these programs was on the order of 15 hours per week per FTE. So an enormous amount of work, mainly just entering information into quality portals for different insurers, for whomever, not taking care of patients, not actually doing the things, but just entering information into portals. And on the right, you can see data from Hopkins looking at their spending, essentially either by person hours or by costs, to comply with all the requirements for all the different quality measures in terms of entering information, reviewing reports, tracking specifications, et cetera, et cetera. And it's on the order of hundreds of thousands of person hours. That's a log scale, and millions of dollars. And frankly, the surprising thing to me was that the claims-based measures are so expensive. And it's because no claim leaves that hospital. No claim leaves our hospital either without someone checking to make sure that there's no potentially negative indicator in that claim, an indication of a safety event, for example. So healthcare is hard, right? It's often harder to change the outcomes than it is to game the system. And so there's an awful lot of gaming, not in a necessarily malignant way, but there's an awful lot of attention paid to the coding piece of how we do all this, as opposed to the quality improvement piece to do all this. And that's in part because of the complexity. There are more than 200 quality measures in the outpatient value-based payment program alone. Like, this is crazy. And so practices that have to try to keep up with us are just drowning in the amount of work they have to do. And sometimes it's easier to just figure out how to upcode and make everyone look sicker and do better that way than it is to wade through this and figure out where you have real opportunities for improvement. Also, as a consequence, administrative spending in healthcare is growing. So 25 to 30% of total healthcare spending in the US is now administrative. It's an increase of 1,500% since, the 70s, though the most of the increase has been since 2000. And on the right, you can see the increase in health insurance claims processors and hospital administrators compared to primary care physicians. The bedrock of our healthcare system, right, have grown at a respectable rate, but nothing like hospital administrators and health insurance claims processors. Vertical and horizontal consolidation is also sort of the story of the last 15 years in healthcare that we've not yet actually seen the end of. So what is this going to lead to? So you can see that among cardiologists, we went from 10% employed to 90% employed over the course of this, decade and a half, which is just a profound shift, right? And where the power is, where the money is, and sort of how we manage all of these non-clinical bits of our existence. And corporatization is next. So, cardiology is already being bought up, as I said, and now we're of growing interest to private equity firms. Now, some of what private equity firms are doing is quite illustrative, revealing, if you will, of all the ways in which we as an industry have not done a very good job of organizing ourselves to be efficient. But private equity is also a short-term profit-driven enterprise, which is not, at least generally, prioritizing patient outcomes. So you can see here that dermatology and ophthalmology have largely been taken over by private equity in certain markets, and that cardiology will, likely be of interest partly because of our access to procedural revenue that could potentially be moved out of the hospital. So that's sort of the corporatization and consolidation piece. And what about the next piece that I said, which is that health outcomes are not only about healthcare quality? Well, what are health outcomes about, you may ask? So here's a nice schematic that talks about what does lead to health outcomes. And you can see, I don't know if you can see my cursor or not, but health behaviors, clinical care, social and economic factors, physical environment, and then clinical care. And I'll come back to the clinical care piece, or I'll come back to the other pieces in a bit, but I'm going to start with the clinical care piece. So we sort of talked about quality of care, right? That's mostly been the focus of these programs. And that to some degree is the easy button. It's under our control. We can see it, we can measure it, we are paid for it. And so that's the place where we have focused most of our effort. But I would argue that access, the other piece of what you might consider sort of in our lane, if you will, is actually even more fundamental for people to achieve positive health outcomes. So we accept as normal that people in this country have no health insurance, right? Like that's not normal in other countries, except for countries where there's not enough infrastructure to have insurance, but in other sort of fully industrialized countries. And if you look at this graph, you can see on the left, among men ages 45 to 54, among Hispanic men ages 45 to 54, in the sort of tan bars, uninsurance rates that exceeded 30%. In the orange, Black patients, uninsurance rates that exceeded 20%, and for white patients that exceeded probably 10 to 12% at its highest. Now, these are largely the working poor, because, and we'll get to it in a minute, but because people who are living in sort of abject poverty have access to some coverage, and there are other, little ways for people to get coverage when they have, when they meet criteria. But a large chunk of this group, this sort of middle-aged men group, is the working poor. It's Uber drivers and, couch delivery people, people working in small businesses, people who are self-employed, people who just don't have a way to access health insurance. That's a huge number, and largely because of the way that we do health insurance in this country through large employers. Now you can see there's, as I sort of alluded to, big racial and ethnic differences in that number. But there's a couple of other things happening in this graph as well. So over here, you can, well, I guess everywhere, you can see a big drop at the Affordable Care Act. And that's Medicaid as well as the health insurance exchanges, giving people access to care. The exchanges are an individual market, that's Obamacare, where you can go online and purchase health insurance through a marketplace, essentially, that pools risk. The other thing that I think is notable about this graph is that on the right, you see people over 65. Everyone's insured over 65 because we've collectively decided as a society that we should insure you if you're over 65. That's Medicare. And the remaining racial and ethnic differences there largely relate to immigration. You have to pay in for a certain number of quarters in order to the system in order to qualify for Medicare. So you have to pay into taxes and Social Security. So there are people who do not qualify for Medicare who are over 65. But for the most part, inequities there and coverage are markedly different. So Medicaid expansion as of February 2024, it's the same now. No states have moved in that time. There was a hint that Mississippi might, but that looks like it may stall. You can see that there's a fairly obvious geographic predilection to who has not expanded Medicaid. And then that correlates pretty closely to the places where I intimated that health outcomes were the worst, right? So all the places where those red areas were, with the exception of sort of the corner, the boot heel of Missouri and sort of some of the Mississippi Delta down by Arkansas and Louisiana, have no Medicaid expansion. And to give you a feel for what that looks like, in Missouri before Medicaid expansion, which took place by popular vote, which I can talk about if people are interested. Before expansion, in order to get Medicaid, you had to have dependent children. So if you didn't have dependent children, there was no scenario in which you could get Medicaid. You had to make less than $2,400 per year, and you had to have less than $2,000 of assets. So if you had an income of $2,500 per year and, an old car that was valued at, $2,500, you couldn't get Medicaid. Now, there's no scenario in which if that is your total income and assets, you're going to spend any money buying health insurance, right? You're going to buy food, shelter. And at that rate, at that, level of income, you probably cannot afford adequate food and shelter. So it leaves a large number of people with essentially no option to get health insurance. And again, largely people in the gig economy, people who are kind of making ends meet, or people who have other challenges and maybe cannot work a full-time job, but don't formally qualify for full disability. So now with Medicaid expansion, individuals qualify up to $20,783 in annual income, which is not huge. That would be tough to live on, but it does provide a much better cushion for people who are really struggling to make sure that they have some ability to access care. Now, as we'll talk about, there are many other issues that I think would suggest that by the time someone is struggling to that degree, we might actually have been more cost effective in covering them earlier. But at least there is a better access to care for people who really need it. But insurance remains pretty uneven across states. So Texas has by far the highest uninsurance rate, and that's a combination of immigration and some decisions around Medicaid expansion. You can see the other states listed on the right, although they're very, very small. Virginia is, I looked this up before the talk, but Virginia is, no, I'm going to have to lean in to see it. There's West Virginia. Virginia is this tan one. This one, I believe. So sort of in the middle, along with Missouri, which is moving down as we have expanded Medicaid, though there's not that many Medicaid non-expansion states to remain above us. And with the Medicaid unwinding, which is when the public health emergency ended, Medicaid redeterminations could start. We're seeing a lot of people come off Medicaid, so it's a story to watch. Now, why does Medicaid matter? Why does insurance matter? Why does access matter? Well, it turns out that having insurance is tremendously important for your health. It provides financial protection for individuals. So healthcare is the leading cause of bankruptcy in this country. But it also provides financial protection for hospitals. So hospitals in states with Medicaid expansion have been much less likely to close over the past decade. Greater access to primary care, ambulatory care visits, prescription medications, all the things we want people to do, right, for health, better adherence to medications and more access to preventive services like cancer screening, better self-reported health, mixed evidence for utilization. I would argue that's a good thing, right? You want utilization to go up. If you think people have been avoiding necessary care, then part of what should happen is that their utilization should go up when they get insured. And indeed, we see that. People who have had knee pain or a breast mass or chest pain or whatever are seeking care once they are insured for things that they probably should have sought care for earlier. And now we're finally seeing the effects looking at lower mortality, infant mortality, arguably the most important, as well as cardiovascular mortality and cancer mortality. Impacts are largest for racial and ethnic minority communities and in rural areas because that's where the bump was the biggest in the gains in insurance. And you can see on the right, for example, some evidence for Medicaid expansion looking at access to heart transplants. So these things matter, right? Having insurance is a big deal in terms of trying to keep people healthy. But there's also a number of other things that lead to healthcare access. So for example, cost, right? I said healthcare bankruptcy is the most common cause of bankruptcy in the country. And so people avoid care due to cost, even if they're insured. And you can see here, this is broken down by race and ethnicity, but I would argue that the number in every single group is too high of people not seeing a doctor due to cost. We're not talking about electing not to have, a tummy tuck or something because of the cost. We're talking about not seeing a doctor due to cost, delaying care due to other reasons, or lacking a usual source of care when you're sick other than the emergency room. Like these numbers ought to be much, much lower across the board. And if we want to think specifically about cardiovascular disease, I think heart failure is a pretty interesting example right now. So heart failure's prescription drug costs are unsustainably high if they want to be on the latest and greatest medication, which presumably they do. So annual out-of-pocket costs can be $36 if you're on an entirely generic regimen, or more than $5,000 if you're on a regimen that includes, Entresto and an SGLT2. And that's unattainable, right? $6,000 a year for medication is a lot of money. If you're living on a fixed income, if you're trying to make ends meet, that's not going to work for you. And we know more and more about how effective those medications are at preventing hospitalizations, at doing the things that we want to do in terms of keeping people healthy, and people just frankly can't access them. We also know that physical access matters, right? And this is, you all will be familiar with this from being in an area where you see urban and rural patients. One issue, particularly in urban areas, is hospital segregation. So we know that hospital care is segregated. Like you can look in any major city in the US and see a hospital that essentially serves the Black neighborhood. And you'll also see a large number of hospital closures in those areas over time, usually leaving a small and inadequate amount of healthcare supply in the most segregated parts of town. And this is a paper we did recently looking at the most segregated hospital areas. So DC, Detroit, St. Louis, Indianapolis, and Minneapolis, based on the dissimilarity index. There's also the isolation index. The details of those don't matter for the purposes of this talk. But segregation is correlated with poor outcomes, particularly among Black individuals who lack access to high quality care, especially in places that are highly residentially segregated. We also know that rural areas are isolated. So you can imagine there's different reasons for being isolated, sort of redlining and housing policies for Black Americans, and essentially economic isolation for rural individuals with the geographic isolation. And there's very little specialist care in rural areas. And we know that rural areas lack outpatient specialist care, and that outcomes are worse, particularly among people with established chronic disease who do not see outpatient specialists, cardiologists being a big part of that concern. So, the last of the three sort of explanations I would offer for why we've not seen the gains in cardiovascular outcomes that we would have liked over the past couple decades is the most broad. So you'll have to bear with me here, but health outcomes are not only about healthcare. We said that. I'd like to go back to this schematic. So clinical care, as you may have noticed, was 20%. So say 10% quality, 10% access. I don't know that we know that, but I think probably access is a bigger driver of health outcomes, particularly early access. But if you look at the things that are included in health behaviors, social and economic factors, and physical environment, they aren't independent of each other, right? We don't typically have someone who's, I guess we do have people who are struggling with one thing, but often you see that a lot of these things sort of run together. And so we're looking at really adverse health effects that tend to go across an entire person, right? Their entire sort of context, the milieu in which they live, that are massive drivers of their health outcomes. And so the idea that what we do in the hospital during one event is going to, drive population mortality, I think is not quite right. Now, it doesn't mean we shouldn't give people aspirin in the hospital, right? We could certainly make things worse by not providing high quality care. And I don't for 1 minute want to sound nihilistic about the things that we can do and do well. but we're sort of not also thinking about all of the other things that really impact people's outcomes. And as you know, especially any of you who treat, young adults, or even if any of you are from the pediatric side, many of these things are sort of present at birth, right? So there are these pretty massive structural failures and inequities that when someone is born, they're born into a scenario in which they are much, much more likely um, to be experiencing poor air and water quality, right? Inadequate housing, be in an area and supported by a family with inadequate income, or with struggles with employment, right? So these things are largely not the result, at least when they are present at birth, they're in no way the result of sort of individual choice. And even for adults, they're not really a choice if you think about those adults having been children. And they're really reflective of a broader context that our patients have been living in for long before they make it to us. So we know that there are striking differences in cardiovascular risk factors based on income, education, and rurality. So I've alluded to all this, but to go sort of back to the basics of hypertension, diabetes, and obesity, if you look at the middle panel, for example, rates of, hypertension in people with a less than high school education are 40%, and people with a college degree or higher, they're more like 22.5%. If you look at diabetes, that's going from, close to 20% down to more like 6%. So these are huge differences. And you can see that for rurality on the right. Again, those go the opposite direction because they're going from rural to urban, or from urban to rural. So you see the lowest rates of hypertension, particularly in urban areas compared to rural areas. But really suggesting that much of the differences that we see in outcomes, and frankly, many of the poor outcomes that we see in total, right? So if you look at just the fact that our acute MI mortality is not continuing to go down, that our CHF mortality is going up, it is driven by the growth in these factors. We're losing the battle against obesity as a country, where diabetes is going up, obesity is going up, hypertension is going up, and it's largely going up in groups without education and with low income. We also know that racism and discrimination drive physiology in a way that works on top of all this, and in a way to sort of really impact some of those base conditions, diabetes and hypertension, for example, and obesity, that then lead to poor outcomes. So certainly there is such a thing as genetic ancestry, and I think we have a lot to learn about what that means. But largely the inequities that we see in the US are based on racism, not race itself, in terms of the ways that people are exposed to adversity. And so you can measure the physiologic impacts of racism and discrimination. And it turns out that those impacts are the same in Black and white people. It's just that Black people are much more likely to have been exposed to racism and discrimination. But it's not a race-specific physiologic response, right? It's a human physiologic response to a series of contextual experiences that, for a lot of historical reasons, obviously has been inequitably distributed. So these are things that act through people's bodies well before they make it to us with their first, heart attack or stroke. We also know that some of the other things we talked about more broadly in terms of things like housing and transit and air quality are also related to historically racist housing and development policy. And so while those policies may predate most of us, they really play out in the exposures that people have across the lifespan, which we know to be very important. So this is from a data set that oversampled Black individuals, which is why the numbers are not the same as a US population. But you can see on top, so Black individuals in pink and white individuals in blue. So Black individuals are much more likely to live in areas with a high deprivation index, which is essentially a composite index of things like income, education, multifamily housing, transportation access, et cetera. And then you can see on the bottom the association between living in a highly deprived area and your hazard of heart failure over time. It's pretty similar for Black and white patients, right? If anything, white patients do worse with more deprivation than Black patients. But the issue, so again, a human physiologic response to a series of contextual circumstances that are disproportionately distributed for Black versus white patients, based largely on, redlining and housing segregation. So evidence again that while I again don't want to say that we should not be doing what we're doing in the hospital, much of what's driving health is really external to the hospital, and perhaps why we do not see continued improvements in health outcomes as we continue to push harder and harder on inpatient quality measurement. So I hope that's not been too terribly depressing. I do actually think that there's the potential for some solutions. And I think, not to be too cheesy about it, but we do to some degree need to return to first principles. So what matters to people, right? It's being able to do what they want to do, spending time with their families and their partners and, getting to age how they wish. And so much of what we've done in terms of corporatizing and really moving healthcare toward this game of measurement and gaming these systems and all these, moving billions of dollars around the country based on readmission rates, we've pretty much failed to invest in better outpatient care, right? We still sort of demand that people come to us at 6-month intervals, and at least for us, come deal with, parking and waiting in a waiting room and all these sorts of things as the way that we're going to influence health. And that's not how health works. And so to the degree that we have ways to think more broadly about helping patients live a healthier life, meeting patients where they are, et cetera, we need to think more expansively about health if we want to actually make people healthy. There's only so much we can do by making better and better mechanical circulatory support, right? Like I'm all for mechanical circulatory support. And I will sort of never forget when putting in, I mean, not me personally, but watching and taking care of CCU patients who are getting, the first, what are those PVADs called? Whatever little VADs were that like sat on your leg with a little spinny thing, the sort of first upgrade from balloon pumps, and watching people sort of turn pink. I'm like, this is miraculous. Like, why are they there in the first place? There's only so much we can improve by, making the technology better and better to rescue people. So some policy solutions to improve care delivery have to explicitly sort of honor values beyond the checkbox, right? It can't only be about checking those boxes, though, again, I think we need to do that. And everyone needs to get their aspirin and statins and all the things. But we need to think about the squishier things like belonging and relationships and wellness. And no, we can't measure those things. And I would not think that anyone should sign up for a registry where you check a box as to whether or not you've made your patient feel like they belong. But I do think there's some, evidence proven ways to deliver care that more explicitly meets those goals. Team-based care, for example, right? I think everyone deserves a nurse or nurse practitioner looking out for them. In cancer care, they have it. You get a care navigator, you get someone who calls you and checks in on you and makes sure that you come for your infusion or your scan or whatever. In cardiology, we kind of leave it up to the patients. We use some team-based care, but we don't use real team-based care in terms of longitudinal management. In terms of longitudinal management in general, we don't necessarily see ourselves as the driver of that ship, right? Primary care usually does it, but we do have longitudinal relationships with people in cardiology. And for patients who have pretty severe cardiovascular disease, we are their longitudinal, sort of primary care, and thinking about ways to really incent that with, again, insurance things and things that make people move around from provider to provider, I think actually do have the potential to help us get at health. We need to do better with community-based care. We don't need to make everyone come all the way in to the mothership in order to see a cardiologist. And though I know no one likes to sort of drive around doing all of the different clinics, there are ways to make sure that we can get access for patients closer to home. And that's in sort of marginalized, disinvested urban communities and marginalized, disinvested rural communities where there's really no access. We need to think about what is a community-based entry point where someone can be providing care and linked to us so that we can provide the backup for the high-tech stuff when we need to. We need to train clinicians from excluded groups and areas, and that's rural, that's from, various minority race and ethnicity groups, to make sure that there are people who are trusted, are likely to practice in areas where there's the greatest need. For rural in particular, there's a huge correlation between exposure to training in a rural area, living and growing up in a rural area, and ultimately practicing in a rural area. And Black and Hispanic physicians are much more likely to work in safety net and other situations where they're providing care to vulnerable populations. So we need to do that as an explicit goal if we actually want to make health outcomes better. Some of this I've already mentioned, but we need to also prioritize and reward access. So we do a good job of measuring quality once you've made it to us, right? So I can measure your mortality rates for bypass surgery, for example. But who are you doing bypass surgery on? And does measuring your mortality rates from bypass surgery make you less likely to take on that person who needs, a redo and is on dialysis? No, there are some patients that are never going to make it through a surgery, and I don't want to imply that we should be doing things that are futile, but we should really be rewarding people for taking care of sick and complicated patients. And instead, a lot of this measurement really disincents people from doing so. We need to put more focus on outpatient care, as I've mentioned, and a focus on the highest risk groups. Many of our quality measures right now, for example, for hypertension control. So say, you're supposed to get everyone's blood pressure to 130/70. The best way to do that is to find everyone's blood pressure who was like 132 or 137 last time you saw them in clinic, and bring them back and offer them a cup of tea and then recheck their blood pressure, and you've done it. That does nothing for anybody, right? That didn't help anybody. But what actually helps somebody is if you went and found the person whose blood pressure was 220 or 250, as we see all the time in our emergency department, and is about to have a stroke. Now, that person's blood pressure may literally never in their life get to 130. But if you bring them down to 150, you've done a massive good for that person. You've maybe given them years of functional life, right? That would be a failure in our quality measurement because you didn't get to 130. I mean, that's sort of preposterous in this day and age, right? We can do better. We need to provide resources to historically marginalized groups rather than take them away. I personally think that most of value-based payments should be scrapped because it's just penalizing based on inadequate risk adjustment, not based on actual performance, and penalties I don't think help anyways. We need to get data and quality baked into our norms. So I'm not trying to say that we shouldn't be measuring and shouldn't be pursuing quality. It's that should sort of just be what we do, right? And then we can try to actually find ways to care for patients in innovative ways. So I'm all for sort of standardization and automation in the sense of, make sure that we're giving every eligible patient an SGLT2. But let's think about ways to then meet them where they are in the community, as opposed to having a building of people reviewing codes to make sure that there wasn't, a non-present on admission urinary tract infection for which we're going to get dinged. And finally, we need to leverage clinician and patient engagement instead of thwarting it. I think very few of us would sign up for a program that said we're going to save money. I don't want to save money. I want my patients to get well. No, I understand that we have an obligation to sort of be fiduciarily responsible, but not for any individual patient, right? That shouldn't be my job as a physician. If you tell me that we're going to sign up for a program where I'm going to try to keep patients healthy, that's very different. Now, that will ultimately save money. But because much of the federal framing has been about reducing costs and not improving outcomes, and that's mostly what they've been looking at these programs to see if they're successful, they're essentially picking up a lot of sort of gaming as opposed to actual health improvement. And clinicians and patients don't want to be part of that program. And frankly, nothing's going to work if you don't have clinician and patient buy-in, because that dyad is sort of the center of healthcare delivery, as you know. And I will say that though this is outside my area of expertise, the policy solutions that are bolder and broader are going to be the ones that actually make a difference in the long run. So the inequities that we see aren't accidents, and the stagnation and improvement in health outcomes is not an accident. It's because we have real structural barriers to health. And those aren't going to go away until we actually structurally fix them. I'm all for developing new drugs and new devices and new therapies, but that's not going to change the fact that if people don't have access to healthcare, they're going to get sick. They're going to get sicker faster. Health is a public good, right? So people sort of got that during COVID, but even absent infectious disease, we're all better when we're all healthy. States that have expanded Medicaid have seen better economic productivity and less criminal justice involvement, actually. So you can make the moral or economic argument, whatever you want, but we really are better off when people are healthy, and we're really failing to provide the basic needs that people need to sort of achieve that when we focus only on the end game of how are we treating heart attacks and strokes. We need to intentionally change things like economic opportunity and education and housing and jobs and criminal justice and the tax code, and that's all well beyond my expertise. but that is what drives health ultimately. And so I'm not suggesting that as physicians, we necessarily need to become expert in those places. But we do need to acknowledge to some degree that that context matters for our patients. And if we're going to be advocates for health, and if we're going to drive toward better cardiovascular health, we have to be mindful of things like insurance access and making sure that people can have access to clinicians, access to medications, and the things that they need to keep healthy. So in summary, health reform focused on paying for quality has not been successful in improving health. And it's for a few reasons, I'd argue. It's focused us on checkboxes at the expense of relationships. It's helped create an administrative burden and financial pressure that have driven our health system in really the wrong direction and taken our attention away from clinical innovation, especially in the outpatient setting. The things that drive health are much, much broader than just aspirin in the hospital. Aspirin in the hospital ought to be done essentially without thinking. And we ought to be thinking more about how to get health into the outpatient setting and keep people from needing us in the hospital. Health policy is obviously my area of interest, sort of unique among cardiologists, but I don't actually see it as being different than any of the things that the rest of you work on in your own personal quests to make people healthier, right? Like it's the same idea as a new drug or a new device or a new approach to care or starting a new, clinic to make sure you see your vascular patients or whatever it is. It's a tool. And it's part of what we can do to improve outcomes and reduce inequities in cardiovascular disease, but we have to use it the right way. And unfortunately, many policymakers have been economists and politicians and not clinicians. And so I think there's ways that we can try to make those policies line up better with what we know as a clinical community is what our patients really need, and try to depoliticize that in some way, right? And really just talk about this is what we need for health. It is our job to improve health, cardiovascular health in particular. And I see policy as one piece in sort of the toolbox of things that we can use to try to make that better. So I'll stop there. I've left some time for questions if anyone has any they'd like to raise. Thank you so much.
Thank you for such a fantastic talk. My name's Kay Ershaw. I'm one of the heart failure cardiologists.
Right.
And I, I always wonder, and is there data out there to help us understand the impact? Because we use this outcomes data over time from hospitals, either on claims or diagnoses. Is there data out there to help us understand the impact of programs like the hospital readmission program on physician behavior in coding and physician behavior in basically coding and diagnosis? Because I feel like over this time period that we're studying and saying, well, outcomes haven't changed, there have been eras during which physicians and hospitals have been motivated to upcode patients to increase the expected ratio, and then downcode patients to improve outcomes, reclassify. There was a new ICD system introduced in the middle of all this. How do you delineate all this data? Is there adjustments made, or are these assumptions that, well, we didn't show improved outcomes because either we're gaming or the coding system changed or reimbursements incentivize people in a different way?
Yeah, that's such a good question. So I will say that the not improving outcomes data are pretty consistent, whether you use claims or, registry data where we have much better clinical information. But it's a tricky thing to it's a tricky thing to talk about for all those reasons. So there's actually been a couple of papers showing just how much gaming there is and how little we should trust the claims. So that I grant you 100%, and it's a very insightful comment. For example, this is a pneumonia example, but that pneumonia mortality improvement that I sort of alluded to early in the talk turned out to be because some enterprising people realized that if you recategorize your sickest pneumonia patients as having sepsis, you improve your mortality for both pneumonia and sepsis, right? You take your sickest patients out of pneumonia, which has lower mortality, and you move them into sepsis, which has higher mortality. So now both have gone down relative to where they started. And so there was a broad shift nationally in patients being reclassified from pneumonia to sepsis. I mean, you just can't possibly keep up with the claims, right? Like hospitals are smart. There's buildings of people doing these sorts of things. So you're absolutely right that there's a lot of complexity in the claims and trying to figure out what's happening. Population level mortality is just population level mortality. So it sort of is what it is. But then you really need to get into better clinical data to understand, kind of the whys, which is, I think, more of what we ought to be doing. The heart failure stuff is interesting, and certainly I'd be interested in your thoughts as a heart failure clinician. My clinical impression is that we're keeping a lot of people alive who just would not have been alive 10 years ago or 20 years ago, right? I mean, it's just astonishing what we're doing for heart failure patients. So we're extending their disease, yet we're seeing higher mortality. And I can't quite tell if it's essentially we've created a sicker population that now has higher mortality. That's sort of it's a bit of a mind bend to think about the chicken or the egg about how people enter that. But I actually think we're keeping people alive longer who have pretty profound heart failure. And so I don't know quite what to make of those increased mortality numbers among the sickest patients.
I certainly agree with you, and there's a disconnect in how the data is presented that
Yeah.
people are living longer, feeling better on medications, delaying things like transplant, but yet when some of this larger data is presented, we're doing a bad job. And is it the patient? And I can tell you on a day-to-day basis, what's happened from when I started as a baby doctor till now is, people there are um, the system is incentivized to call someone coming in with edema, heart failure with preserved ejection fraction. If you're
Right.
coming in with missed dialysis, in one area you're incentivized to call it heart failure, and in another, when you're getting punished for it, it's actually hypertensive urgency.
Right.
So this is happening not generation to generation. This is happening every few years as policies change, as CMS reimbursement changes, and it muddies the water. But if you look at more granular data, if you just look at clinical trials enrolling the same patients, patients are living much longer
Right.
if they meet eligibility for the trial. If you look at registries with strict entry criteria, patients are living much longer.
Right.
We don't know if it's a lead time bias or it's treatment, but it seems to be happening. So I always find it challenging. Second question, I don't mean to monopolize the question time, is if ha- if if the root of all evil is failure to prevent, what metrics should we use to hold inpatient programs accountable? If some of these metrics seem to modify behavior without changing outcomes, should we should it be a process-based assessment of hospital performance rather than an outcomes-based or volume-based? What would you suggest to distinguish
Yeah.
good performance from poor in a hospital setting?
That's a really good question. I think for the reasons that you just outlined, it's very difficult to actually distinguish good performance from poor, because the things are just too easy to game. I think where we are likely better off is something sort of like how comprehensive cancer centers work, or sort of how US News has gone to this, honor roll, the top 20 whatever, as opposed to trying to say that you can parse everyone out one by one. It's to sort of say, there are, if you provide the following services, you're providing transplants, you have VADs, you're doing advanced ablations, you're doing all these things, you are a cardiovascular center of excellence. And we're going to stop kind of nickel and diming you on each of these little things, but we want you to demonstrate what you're doing in a few key areas. So if you're a cancer center of excellence, you have to have prevention, you have to have cancer epi, you have to have, a certain clinical trial enrollment, and then you have navigators and sort of a whole system. I'd be much more in favor of trying to incent cardiovascular disease groups to work more as a system and meet certain sort of requirements, and then leave the individual ticky-tack measurement to the individual centers to say, yes, you need to know what proportion of your patients are leaving the hospital on SGLT2s, because we are looking at your overall, survival, readmissions, whatever, but we're not going to take $4 away from you because your readmission rate went up 0.2%. We're trusting that you're working to improve those things, and we want you to report back on an annual basis to what you're improving, or something like that. Much more how the cancer centers work, and less how the current sort of one size fits all, death by 1,000 paper cuts approach to cardiovascular care. no one, and I've actually not floated that idea to anyone who runs things that could make a comprehensive cardiovascular center, but I think it would be kind of cool. So maybe I'll write that up next. All right. Well, thank you all for your kind comments in the chat. I think we're at time unless anyone else has a question. I'll just say thank you all for being here. I appreciate everyone showing up early to hear about this stuff. And I'm easy to find. I'm the only Joynt Maddox in the world, as far as I can tell, if anyone has particular interest in this and wants to follow up.
Thank you so much. And thank you for being here so early on your end.
Oh, I should put your slides back up to put up the thingy, right?
Oh, it's okay. Well, yes, you could do that. I also share it out, but thank you.